So neurology itself will start off with coma. And the best way to end up doing, the coma is a lack of wakefulness and awareness. So what you end up having to have for coma is a lot of times a Glasgow coma scale of less than 8, or you have to have somebody, Glasgow coma is less than 8, both of your hemispheres have to be out. If you are in a coma, both cerebral hemispheres have to be very dysfunctional, or your brainstem has to be dysfunctional. That's quite an injury pattern, isn't it? You don't become into a coma unless both hemispheres are out or a brainstem is injured. Most people will define that as a Glasgow coma scale of a less than 8. So here's your Glasgow coma scale. You have to end up, it's probably worth 1 point. They always put this sucker in there somehow, They give you a patient, presents as, they give you the neurological exam and said, what's the Glasgow coma scale? So either you have to memorize it or guess, right? Most of us, people that do it all the time could actually just put it out. But, let's face it here. The ER doctors have cheat sheets, right? They just circle the different stuff. I carry something in my pocket that I could just look at. Nurses have cheat sheets. ICU, why do they make you memorize all this stuff? This is a way to talk to each other. So if you want to get a little idea maybe, I always get eyes are worth 4 points, mouth is worth 5 points, hands are worth 6. 4, 5, 6, they add up to 15. Then you just got to figure this out. So anytime that you're not awake, you're not alert, your eyes are closed, you're basically going to be a less than 8 in a coma itself. The evaluation of a coma, there's not a protocol. There is honestly, if somebody comes in the urgent care or the emergency urgent care section or a hospital and said, what's the protocol for evaluation of coma? There isn't one. Because they're markedly different, aren't they? A 104-year-old comes in from the nursing home. 104-year-old comes in from the nursing home comatose. A 20-year-old co-ed that was last seen at the cocaine party, 2 hours ago, comes in comatose. Aren't they completely different evaluations? The drunk that comes on is on the ventilator and is comatose. I discharge him the next morning from the ICU. Pull the tube, have breakfast, get out of here. They're completely different evaluation tools. So the situation, the timing, the age, the medical problems, is there trauma, is there not trauma? I would say the most important thing for you, again, is the directed history. Try to get it firsthand. Oh, sorry, you can't get it firsthand from a comatose person. But you could try to get it secondhand. Most of the times we get it fourth hand, right? Somebody told the paramedics, and the paramedics told the ER doctor. The ER doctor now is telling somebody, which may be you. You're getting a fourth hand. Try to get it as close to the source as you can. That will be important with seizures. It's important on comas. It's important almost in a lot of stuff. Is talk to the person as best you can. The physical examination should give you very much a clue to the source after you end up having the history. This is a time to get naked. Not you, the patient, get naked and look, right? The older person in the nursing home, you may have the ugliest decubitus ulcer without a fever, have a sepsis program that you think it's something else. So you could end up having needle track marks, between the toes because they ran out of the neck areas and everything is sclerosed. The abdominal examination for, let's say, liver failure, etc. So this is the part, now we'll literally take off all their clothes, and I still do a directed exam. It's funny, a complete neurological examination, my neurological exam probably a lot of times initially takes a minute. It doesn't take very long. Heart, lungs, tummy, look at their skin, flip them on over, do a directed neurological examination, and off you go to the races, right? That's how the experienced clinicians get out of there a little faster. The studies itself, again, depends on your presentation. So you get, CAT scan MRIs. Does the drunk need a CAT scan? Maybe yes. Maybe yes. They may be drunk, but did they fall over? Did they have an intracranial hemorrhage? Did somebody with a Coumadin that went into a coma, did they have a bleed? Not everybody with a coma needs an MRI, CAT scan, EEG, CSF, etc. Right? Direct your therapy very appropriately. One of the most abused tests that I think that we end up doing for the comatose people is a drug screen. I get the results after they get discharged to the hospital, or I get the drug screen when everybody knows they're a drug addict. Do I have any reversal agents for most commonly abused drugs? If you think about it, what is a drug screen helpful for? I think you should drug screen things that you have reversal agents for. Doesn't that make sense? Aspirin makes sense. Tylenol makes sense. But a lot of times, if their alcohol level is high, what am I going to do with that piece of information? Now, if it's really high, that's okay, because I know what's the problem. But I'm talking about abused drug screens. Then some people send out serum drug abuse screens that, test everything in God's creation, just like CSI. CSI gets back results right there. We get the results, and they send them back, and they're already discharged, and then you find out what it is. And a lot of times there's false positives and false negatives. I'd really question yourself, how often is a drug screen really helpful for you? Treat the underlying cause. That makes a lot of sense. If it has a reversal to it, treat the underlying cause. Treat the electrolyte disturbance. Treat the sodium of 170, the sodium of 110. Prevent further damage is the most important thing that you could ever do. If you have an antidote for your reversal, right? If your coma is related to a sugar of 30, treat it. If you don't have something reversible with the underlying cause, then prevent any further damage in that comatose patients that you have. Hypotension. This is where you want to call it euboxic, right? Not, blood pressure. You don't want them hypoxic. You don't want them cold. You don't want them warm. You don't want them low sugar. Those are the areas that when we talk about stroke, when we talk about coma, are the most important things that you could possibly do. The prognosis will be covered. Randy, I think, covered the prognosis. No, he didn't. On the syllabus extras under resuscitation, there's a prognosis scale for people that have cardiac arrest. There's also a prognosis scale for coma. Look at that. Poor if no pupillary light reflexes on the initial exam. Pupillary light reflexes on the initial exam. Now that's poor, but it's not zero. Then it says, or no motor response, no better than posturing at 24 hours. We prognosticate at 0, 1 day, and 3 days. 3 days is a big, big prognostication. If you're sitting there with your eyes open, if you're doing no better than posturing, if you're still kind of, quote, in a coma, your prognosis is terrible. Not 0, but it's terrible. So on the initial day, don't prognosticate somebody that's 20 years old with an Elavil overdose because they have no pupillary light reflexes. Those people could actually appear dead for a couple of days and all of a sudden wake up and do just absolutely fine. They won't do fine if they've been hypotensive, hypoglycemic, hypothermic, and they have secondary brain injury where your brain's trying to recover. Coma could go then, we call it when you come on into the emergency room, I think somebody has helped us out because most people come into a coma into the emergency room have their eyes closed because it's really freaky for us to have them come in with their eyes open. We don't like that. So I think, again, whoever made our bodies said, when you go to coma, close your eyes because it bothers the doctor. Now, when you end up recovering from the coma, when you recover from the coma, you go from an eyes closed coma to an eyes open. All of a sudden, the nurses said, they're awake, but I say, no one's home, right? They're in a persistent vegetative state is another terrible thing that could end up happening. Eyes closed to an eyes open, that means their brainstem is recovering. They're going to a sleep-wake cycles. They get, I'll close, I'm going to sleep now, I'm opening up. But they have a complete unawareness of their self and their environment. They have no purposeful movement. They can move based on reflexes. They have a preserved brainstem. Most of us would not want to function without our cerebral hemispheres. This is the persistent vegetative state. They are not dead. Their hemispheres are very dysfunctional. Their brainstem is intact. They have pupillary light reflexes. They have doll's eyes. They could breathe on their own. They could open and close, but they're unaware. The Terry Schiavo, case, a tragedy. This is tragic. When I end up saying the prognostication, I call this terrible. So when I end up looking at posturing at 3 days 3 days after the injury, the prognostication for independent dwelling, or I call it wheelchair dwelling, or I could tolerate this type of a life.